one being the the control the pharmaceutical companies have over releasing drugs, and probably the lack of strong oversight on the part of the FDA. So, but that's next week. So this week, let's jump into the opiate healthcare crisis. I'm going to open up Zoom. Assume you've all used Zoom. I'm sorry, Zoom, chat, Kahoot. Sorry. I was looking at Zoom as I was saying that. So I'm going to open up Kahoot. Assume you've all used it. And I'm going to just kind of go through a series of questions related to the opiate healthcare crisis. That'll set the stage for our conversation. Okay, so if you can jump on this Kahoot exercise once the game pin opens up. So last time I used it was August 23rd. So did it with the School of Pharmacy faculty actually. So the opiate epidemic in America. Okay. Yeah. So, I've been studying this area for the past 7 or 8 years. And prior to the pandemic, it was actually leveling off, at least in terms of one of the key measurements, which is people who died from opiate overdoses. And it's been accelerating over the past 2 or 3 years in terms of deaths and estimates of people who are suffering from opioid use disorder. So big part of that is the increased access to fentanyl, but I'm sure there are other factors going on as well. So how many Americans have been killed by opiates in the past 20 years? Yeah, so it's been significantly more than 600,000. And, this started out really with prescriptions. And then as it became more difficult to get prescriptions, people first went to heroin, and now fentanyl is a big part of the epidemic in terms of the percentage of people who die as a result of opiate overdoses. So there's a report out of Stanford about a year ago, and they're estimating that unless we do something dramatically different, they're estimating how many more Americans are going to die before the end of this decade. Yeah, so if you selected this number here, more than 1.2 million, that's what the Stanford Lancet report is predicting without major changes. So we're over 600, so we're probably looking, unless something significantly different happens, probably looking at more than 2 million people. 2 million Americans, I should say, because people are dying in other countries too, but not nearly at the same rate. So how about the risk of providing naloxone to someone you merely suspect of being in an opiate overdose? Is that a good decision? Yeah, okay, good. Yeah. So as it turns out, naloxone is pretty benign, and there really is no known risk to giving it to someone who is who you suspect but is actually not in an opiate overdose. So, and it's highly effective to people who are in opiate overdose. So, opiate overdoses start with prescriptions, heroin, fentanyl. So they're all opiates, and naloxone is highly effective if you get somebody in time at reversing that. So in 2022, the estimated ratio of overdose reversals with naloxone to opiate overdose deaths was what?
Have you heard about opioids, also called narcotics? Maybe you or your parents have been prescribed some. Narcotics are used in everyday medicine, but I bet you probably also heard all the bad things about them too. Let us clarify and educate you on the risk of opioids and overdoses. We are currently in an epidemic with opioids.
Yeah, so the honest answer is we don't know. I was actually on a webcast earlier today with a group in New Jersey, and they are losing about 2,500 people a year to an opiate overdose, and they have data on first responders and public safety and how many doses of naloxone they give, and those numbers are in the range of 5 to 1. What's not captured are the bystanders, the people who are there, often used as themselves or friends or family, and so anecdotally, I know the Massachusetts Department of Public Health, because I've talked to them about this, estimate it's probably more like 10 to 1 or higher, but there is no way of knowing factually because most of the doses of naloxone are given by people who don't have a mechanism to report. So, we do know public safety and first responders, EMT and police officers, fire. We do keep track of that, and but that's probably less than half of what's actually going on. May even be less as a percentage. So the message here is that um, without naloxone and without easy access to naloxone, which does not exist in most places, the overdose numbers would be considerably higher. We don't know how much higher, but they might be 2, 3, 4 times as high. If you can believe that, even though we've already lost well over 600,000 people. So per the CDC, in nearly what percent of overdose deaths someone else was present?
We've been investigating the impact of prescription drug overdoses in America for some time on this program. As you may know, someone dies every 19 minutes in this country because of such an overdose. And today,
Yeah, their estimate is about half. And So, as we know, if somebody is there and has naloxone, the chances of somebody surviving are pretty good. Not guaranteed, but they're pretty good. But unfortunately, that is often not the case. In 2021, what percentage of Massachusetts prescribers of opiates were also waived to prescribe buprenorphine?
Have you heard about opioids, also called narcotics? Maybe you or your parents have been prescribed some. Narcotics are used in everyday medicine, but I bet you probably also heard all the bad things about them too. Let us clarify and educate you on the risk of opioids and overdoses. We are currently in an epidemic with opioids.
Yeah, I wish it were 75% or more. Most summers I have a surf student. I think it was in 2018 or 2019, the surf student decided to replicate a study that had been done at BU 5 or 6 years earlier, which was to determine how many prescribers of opiates in Massachusetts were also had been waived, because at that point you needed to be waived to also prescribe buprenorphine, which is more commonly known as Suboxone. This is Suboxone, methadone, and naltrexone are the FDA-approved medication-assisted treatments for people who suffer from opioid use disorder. So at that point, there were I believe the number was four, per the DEA, 48,000 prescribers of opiates in Massachusetts, and less than 5% in 2019 had also received a waiver to prescribe Suboxone or buprenorphine. Those numbers have ticked up, but my guess, and I don't have current data, but my guess is that it's still well under 10%, unfortunately. So as it turns out, PAs, so physicians, PAs, and nurse practitioners are all eligible to prescribe buprenorphine, and so there's growing interest in making it easier, but we're still well behind the curve here. So how about what percentage of naloxone is distributed via pharmacies in the United States?
Hello and welcome. I'm Dr. Ingvild Olsen, the Director for the Center for Substance Abuse Treatment here at SAMHSA. We are very pleased to be able to offer this webinar as you prepare your FY22 application for the SOAR grant program. As you know, the SOAR program aims to address the...
Yeah, so based on the information we have, the number appears to be under 20%. Most of the distribution happens through nonprofit groups, harm reduction groups. If you or I go into a pharmacy today, we can buy, now naloxone is available over the counter, but it has for several years been available without a prescription in most states, including Massachusetts. And the insurance will pay for it up to your copay. But so for the most part, well, I should say almost exclusively in pharmacies, you're going to see the nasal spray. There is a syringe-based naloxone that which is what most of the harm reduction groups, particularly outside of Massachusetts, use, and they go to hotspots and they distribute these syringes with naloxone vials to people. And the reason they do that, it's the lowest cost version of it that they can find. Worked with a group, they're based in California, and they have a contract or an agreement with Pfizer, and Pfizer basically gives it to them at cost, which is about $1 a vial, which is about the cost of naloxone, and they in turn basically give it at their cost to harm reduction groups across the country where they can. And so the estimate is that those types of harm reduction movements are really accounting for over 80% of the distribution of naloxone. So but we're still, still missing a lot. So the CDC estimates this percentage of opiate deaths could be prevented by increased access to naloxone.
Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I'd like to welcome you to today's COCA call.
So their estimate is that 60% of the deaths could be prevented if naloxone were more plentiful or easier to access. And it's a drug that cost almost nothing to produce, but because of the stigma around drug use, that it's just not always a popular thing or an easy thing to do. So we have an antidote, but we have a challenge. We have barriers to try to reach the people who really need it. Right. So ideally, you can think about, the Boston Medical Center and the groups of people that hang around there. Many of them, are addicted to opiates. Not all of them, but many of them are. And having, somebody there or having the supplies easily accessible, hot spots, getting them to the hands of people that are going to. So we're getting increased information about where the hot spots are, and they're across the United States. They're not just in urban settings like the Boston Medical Center. They're in affluent communities as well. But increasing the access to naloxone, which is a low cost antidote. The CDC estimates we could make a major impact in reducing deaths. Unfortunately, not really curing the problem, because the problem is much deeper, but it would at least give people a second opportunity. So what percentage of people die in a home, according to the CDC?
Each day in the United States, over 120 people die from an opioid overdose. Many of these deaths are preventable. In fact, when someone nearby is experiencing an overdose, your awareness.
Yeah, their estimate is that over 80% of people die in a home. So that, again, is key, because many times there are people there with them. And community pharmacists generally discuss the risk of addiction and overdose with patients prescribed opiates.
Did you know that opioid deaths in Australia have doubled in the last decade? And prescription opiates contribute to 2 deaths and 75 hospitalisations every day? These harms are not just from taking too much. They can...
Yeah, we have done studies of community pharmacists in Massachusetts, and it is rare that a community pharmacist will discuss these issues with people prescribed opiates. Unfortunately, it's also rare that the prescriber will discuss this. There are at least 16 states that require by law that the prescribers discuss the risk of addiction and overdose with patients. Massachusetts is not one of those communities, however. This is a duplicate, so I'm just going to skip this. So how about alternatives to patients prescribed opiates? So unfortunately, based on the research we've done, based on the literature that's out there as well, but we've done firsthand research on this topic at MCPHS, and as I mentioned, there are 16 states that have a law that it's called the right to know law, which basically says if I'm going to prescribe an opiate to somebody, then I have a legal, not just an ethical, I have a legal obligation to talk to them about the risk of overdose, the risk of addiction, and the alternatives that are available to them. And that law does not exist in Massachusetts. I've been to the State House twice to talk to legislatures about it. They all think it's a common sense, no brain idea, but they have not willing to act on it. So the opiate epidemic is getting the attention and resources necessary from policymakers and healthcare organizations. Yeah, so it's interesting. In 2013, Massachusetts declared the opiate epidemic a public health emergency, and in 2017, the U.S. government did the same. And it felt as though it was often a front page above the fold issue, at least in the public health and the healthcare community, until the pandemic came along. When the pandemic came along, the focus was on COVID, which is totally understandable. And since then, the problem has really escalated. But the level of interest in this public health and healthcare epidemic doesn't, to me at least, feel as though it's getting the same level of attention and resources that it should. And I think one of the reasons why, you look at how much energy and attention COVID got, and we could do something similar for the opiate epidemic, but I think there's a lot of barriers to that. It's not, and I think it starts with stigma about people who suffer from opiate use disorder or any drug disorder. So on average day in 2022, how many Americans died by overdosing on opiates? Yeah, so the number is, as reported by the CDC, is over 200 now. See the trend here, starts in the 90s, and this is primarily when opiates start to be prescribed to almost anybody who wants it. And we see a steady increase year after year. This dip right here is before the pandemic. We saw it in Massachusetts, and we interviewed emergency room physicians. We were doing a study about how they dealt with opiate overdose that presented. And they said, we asked them why, and the anecdotal information was, we think it's increased access to naloxone. And then you see it skyrocket. It's really, this is 2022. If you draw the line for 2023, the curve continues almost in a linear fashion upward. And so these are all deaths, but 75% of them are related to opiates. So, yeah, that's kind of, that's where we are today. And with Stanford has recognized, Stanford University studies recognized, this is not going to get better unless we change course somehow in the public health and healthcare setting. So I'm going to ask you 4 questions that were asked to the general public by a research group. So how much blame do you assign to the pharmaceutical companies for the American opiate epidemic? Okay, so You know, if you don't know, you probably should know that the company by the name of Purdue Pharma, they brought to market a drug called OxyContin, and with that drug being come to market, they invested in one of the most brilliant marketing campaigns that had ever happened in the United States, let alone the pharmaceutical industry, and it really changed the way that pharmaceutical companies market to healthcare providers, because what they essentially did was they convinced the American healthcare industry, doctors, nurses, oversight groups, that opiates could be safely prescribed, and I mean we know now, and you know, I don't know why we didn't know then, but that was a lie. That there's no such thing as safely prescribing opiates. Everybody had been trained up to that point to know that opiates were highly addictive. People were susceptible to overdosing and becoming addicted. And so as a result, up until the mid-90s, opiates were only used selectively, which was for end of life, cancer, and a few other debilitating chronic diseases. We did not prescribe it for acute diseases. Dentists didn't prescribe it for wisdom teeth removal and the like. But that all changed, and we became a culture where we ended up 1 out of 3 American adults by 2015 had received an opiate prescription in the past year. So so how much blame do you assign to doctors and other prescribers? Yeah, so you know, the thing is that we would not be in this situation had the American medical profession not rolled over for the pharmaceutical industry, and in particular for Purdue Pharma. And you know, I'm not a healthcare provider, but I scratch my head and I wonder how could these highly educated, informed individuals have believed a lie from a pharmaceutical company. But in any case, that horse is well out of the barn. How about the individuals who use opiates? How much blame do you assign to them? Okay, yeah. So I'm going to show you how you compare to the general population. So, okay, so about 50-50. How about the FDA and other government agencies? Okay. Yep. And I'm going to show you how you compare when we get to the slides in a couple of minutes. So when opiate is prescribed, patients and parents have the right to know what? Yeah. So the it, the right to know law basically provides that when you prescribe an opiate, you have to by law discuss the risk of addiction, the risk of overdose. The alternatives are available. And I just add in naloxone may save lives because that's to me seems to go hand in hand with, if you're going to prescribe a drug that may cause a problem, you should probably also describe something that could save somebody's life. And the thing about opiates is that, because there are a lot of studies where somebody has a level of opiates that may not be fatal or dangerous to them, but gets in the hands of the wrong child. There've been many cases where grandparents or others have had fentanyl patches on for legal and legitimate reasons, and been hugged by their grandchildren, and the grandchildren has gotten into a very risky situation. So the idea of having naloxone available, which is not going to hurt anybody, is to me is a no-brainer. So most people dispose of unused prescription opiates. Yeah, so there have been a couple of studies, one by the Mayo Clinic, one by Johns Hopkins, and they studied their patients who had been prescribed opiates after surgery. And I think the number is like 65% in one study and 80% in the other, found that that percentage of people did not use all of the opiates prescribed, and almost all of them kept the opiates in their medicine chest just in case. And those studies both said that they should be prescribing less opiates, which I totally agree with. But the other side of that coin is that people need to be educated that these are lethal drugs, and they need to be, if once you're done with them, you need to dispose of them, or at least at a minimum, put them in a place where nobody can have access to them, just like you would a loaded gun, because in some cases that's exactly what they are. So, and unfortunately, we're not doing a great job with that, but we could. We know there's millions and millions of prescriptions hanging around people's medicine chest. Yeah, so I think now the question is, how much of a commitment are we going to make to that? Because it's low cost, highly effective, but still not as easy to get as it should be. If you think about COVID testing, how easy that was. So I'd like to learn more about how I can help solve the opioid healthcare crisis in America. Yeah, and I'm never bothers me if people say they're not interested, because everybody has things that they're interested in. This is this is one of the reasons why when people talk about, we'll put naloxone at every locations throughout cities, and people say, well, what about this other disease? What about putting other things, making other things as easily available? So it's there's a lot of barriers to this happening, but okay, we'll skip over this for now because I want to share some stuff with you first. Okay, so I'm going to go to the slides now. Okay, so let's kind of recap the current situation as to where we are. So this is primarily an American problem. There are other countries, Canada and parts of Europe, that have struggled with opiates, but not nearly to the extent the United States has. So it's we are off the charts when it comes to this healthcare public health epidemic. So so when I started working on this 7 or 8 years ago, the number of people who died every day was 91. At last count, it's up over 220 a day, and well over 650,000 people have been killed by opiates in the United States. So these are just U.S. numbers. Here's the the chart that we kind of looked at already. The other thing that so some people say that deaths are just the tip of the iceberg. So there was a study done at BU in 1998 by the public health department, and they their estimate was that 1 in 20 or 5% of Massachusetts residents who were over 11 had opioid use disorder, or said in a more crude way, were addicted to opiates. And that number, I think, really startled a lot of people because the CDC, for ever since I've been working on this, has had the number 2.5 million Americans. If 5% were the right number, and you could, if you could extrapolate the Massachusetts study to the country, then we would be looking more at between 10 and 15 million Americans who suffer from opioid use disorder. And so I'm pretty sure that it's much higher than 2.5. I don't know, and I hope it's not as high as 15 million, but we know it's millions of Americans. So in 2018, there was a survey of Massachusetts residents, and they asked them the most serious problem facing Massachusetts, and 71% listed the opioid epidemic. So that the truth is that this. Hold on one second, please. So other issues, cost of healthcare, high taxes, etc. So what we know is that unequivocally the problem has gotten worse, not better, unfortunately. The other thing is that at that time, 3 in 10 people knew somebody who had died from an overdose. Unfortunately, I think that number's probably almost definitely has gone up, and so we don't have time to go through it today, but there was a really well done documentary by PBS saying "Understanding the American Opioid Epidemic," and it gives you a really good flavor for how it originated and the impact it has. So I would recommend that if you want to learn more about this particular topic. So let's talk about public perception. So if you combine these two bar chart categories, the two blue ones, but it's how I look at it, because I think a great deal or a moderate amount, people were asked the same questions I asked you, which is, how much blame do you ascribe to the pharmaceutical companies? 83% were on board with the pharmaceutical companies, so you could put me in that category. 76% doctors and dentists, you can put me in that category. Only 64% the government, which I think probably because people don't realize that the responsibility of the FDA and other government agencies and how they drop the ball. Because I know almost all of you, ascribed some or all a great deal of blame to them. But the thing that is very concerning is this bar right here. And I think you guys will split 50-50 on it. Individuals who use opiates. So I'll give you one argument that why this may be false. And I certainly would, you could put me in the gray area here. Which is, for the most part, people who are suffering from opioid use disorder started either through trusting a doctor, a physician, a dentist, or through getting their hands on some kind of a prescription or drugs, and then went off the rails from there. Because for people who are prone to addiction to this drug, it usually doesn't take a long period of time before there's no turning back from it. And so, and the thing about addiction is that there's an increasing argument we should view this like we view any other chronic disease, like diabetes or hypertension or other things. And if we treated it that way, then we'd have a chance to to start to deal with the problem much more aggressively. So, but in any case, one of the big issues here is the stigma, the shame, the guilt that these individuals face, as long in addition to that a large segment of the population, including healthcare providers, also feel that, hey, self-inflicted wound, so okay, so we talked about the pharmaceutical companies. They sold the big lie to the healthcare profession. And I've worked in industry most of my life, so I know companies are always going to, many companies, not all companies, but many companies are going to give you half-truths. And I'm not even sure that this was a half-truth, it was probably just a total lie. But in any case, buyer beware, particularly when you're dealing with highly educated people. And what I still don't understand is how the American medical profession bought the big lie and continued to proliferate it, even when the epidemic was growing throughout the 2000s. So I'm gonna have you listen to about a 5-minute talk from Dr. Kolodny. He's over at Brandeis. He's been one of the outspoken people when it comes to the opioid epidemic. So let's listen to what he has to say.
I think one of the main reasons that we have failed to respond appropriately to the opioid crisis is that it was misframed, and intentionally so. Certainly by 2000, 2001, there were reports coming from Appalachia, New England, about OxyContin overdoses and addiction. And it was clear we were having a problem with opioids. From the beginning of the crisis, the way the issue was framed, particularly by pain organizations that were getting funding from opioid manufacturers, the way the issue was framed for policymakers was as if all of the bad things that we're hearing about, all of the opioid harms, policymakers were told were limited to so-called drug abusers, and that millions of patients were being helped by the increase in prescribing. And so policymakers were told that, your challenge is to try and do something about this drug abuse problem without making the chronic pain problem worse. Millions of Americans are suffering from chronic pain. And if you were to promote any kind of intervention that would result in reduced prescribing, you'll be punishing the pain patients for the bad behavior of the drug abusers. So you've got to balance these two competing problems. And the reality is that we don't have these two distinct groups. And opioids are not safe and effective treatments for the vast majority of people suffering with chronic pain. Millions of patients with pain have become opioid addicted. Thousands of patients have lost their lives. And so the opioid crisis is not an issue of drug abuse. It's not an abuse crisis. If you frame it that way, it suggests that the problem is people behaving badly, taking dangerous drugs because it feels good, and they're accidentally killing themselves, and that maybe the intervention is to make the pills hard to crush so people can't abuse them. It's not an abuse crisis, it's an addiction epidemic. The reason we have historically high levels of overdose deaths, the reason we're seeing heroin and fentanyl flood into non-urban areas, the reason we're seeing a soaring increase in infants born opioid-dependent, children winding up in the foster care system, outbreaks of injection-related infectious diseases, is because we've had this very sharp increase in the prevalence, the number of Americans suffering from opioid addiction. And if we're going to bring the epidemic under control, we have to stop creating new cases of addiction through more cautious prescribing, and we have to see that the millions who are addicted have access to effective treatment.
Okay, so we have done some work in terms of reducing the number of prescriptions. Not as much as we should, but we've done some work there. The treatment, is still probably much further away from being where we need to be than, and I think that's really what the Stanford study is telling us. So what the CDC tells us is that as many as 1 in 4 people, so think about that, 25% of people who receive opioid prescriptions long-term, and they define long-term as 90 days or more, those people, 25% of them are going to struggle with stopping. And then what they also have pointed out is that for people who struggle, it doesn't take long for them to, after a short period of time, the likeliness of dependency sets in. So in 2015, a study done by the National Institute of Drug Abuse found there were 1 in 3 Americans who had been prescribed an opiate in that past year. I think it was 2012, we hit the peak of 250 million opiate prescriptions, and that was per the CDC. I think we're down to about 150 million the last time I looked, and it's all on the CDC website, so still way off, way outlier compared to other countries. So when you look at other countries in terms of availability, and then of course the related deaths, we are an outlier, okay, and that's widely known. So, we talked about reason 3, the FDA and government regulators, and so I'll read the quote from Dr. Kolodny, who, by the way, has been a frequent target of the pharmaceutical industry and some healthcare providers who have a very difficult time listening to what he has to say. He says, I believe we wouldn't have had an opiate epidemic if the FDA had done its job properly. So I think that is pretty clear cut, and I agree with that 100%. So here's the issue with blaming the people who are addicted. It's the circle of stigma. So people look at somebody who is suffering from a drug addiction, feel as though that person has some kind of a character defect, and they feel no responsibility or obligation to treat them like we would treat somebody else with a chronic disease. And the people who are addicted typically, there's a great deal of guilt and shame. Unlike other healthcare issues, they're not going to step forward and say, I need help or I have a problem, generally. So there's a self-feeding cycle of stigma, and that keeps people in the dark, that keeps policymakers and others from doing the things that they should. Massachusetts, which holds itself out to be a bastion of progressiveness, has not been willing to do simple things like require healthcare providers to inform you about the risks and the alternatives. So, and I think a lot of this has to do with the stigma issue. So, okay. So what can you do to help one person? So, it's when there's a tidal wave like this, one alternative is to say, there's nothing I can do about it. And the truth is that there probably is nothing that most people, if anyone, could do about the overall problem. But if you break it down to one person at a time, you might view it a little bit differently. So, that's the inspiration that people like Mother Teresa and others have been, telling people, right? So, don't, you may not be able to solve the problem, but maybe you can change it. You can make things better for one person. So, so the first thing I want to talk to you about is naloxone. So this used to we up until the pandemic, we used to do weekly trainings on how to use naloxone, and up until just before the pandemic, there was a level of complication with it. You had to assemble the naloxone kit, but now it's a very simple matter. So really, what I want to talk to you about is how to recognize somebody in overdose, and then a couple of things that you can do to help that person. So the first thing is, how do you know if somebody's in overdose? So I'm gonna show you a short video of somebody who is play rolling what somebody's gonna look like in an opiate overdose. But if they're not breathing, or their breathing is shallow, if you can't wake them up, and then there are other indicators: blue lips, pinpoint pupils, etc. You should make the assumption they're in an opiate overdose. So let's watch this video. This guy is showing you what somebody who's in opiate overdose is likely to look like.
Let's begin with understanding what an opioid overdose is and how it affects the body. Opioids work by interacting with receptors in our brain. The opioids fit into these receptor sites, sort of like a key fits in a lock. What makes opioids potentially so dangerous is that these same receptors ensure we keep breathing. An overdose happens when more and more opioid molecules latch onto these receptors, overwhelming the brain's ability to keep us breathing properly, or even at all. Because someone suffering from an opioid overdose may appear to be simply sleeping, it's important to know the signs to look for. Specifically, breathing becomes very slow and shallow, erratic, or has stopped. Snoring or gurgling sounds are made. Pupils become pinpoints. There is a loss of consciousness. The person is unresponsive to outside stimulus. The body is limp. Pulse is slow, erratic, or not there at all. The face is pale and clammy. Fingers and lips turn blue or purple, and the person may also experience vomiting. An opioid overdose deprives the body of oxygen, which can cause vital organs, especially the brain, to shut down. After 3 to 5 minutes without oxygen, brain damage starts to occur, soon followed by death. Fortunately, there is a medication that can temporarily combat opioid overdose symptoms, buying critical time for paramedics to arrive. Naloxone is a competitive antagonist to opioids. It works by knocking the opioids off the brain receptors they've latched onto, allowing the person to breathe again, and temporarily reverses the overdose.
Okay. So that's what somebody might look like. If you come across somebody, or somebody you know, then there are some basic things that you can do. So it's called the 5-step approach. So the first is to stimulate. And you want to just do this for a couple of minutes before you call 911. And then if you have naloxone, you're going to administer it. And if the person has not started to breathe on their own, or if you don't have naloxone, then you can do rescue breathing or CPR if you know it. And then the fifth step is to stay with the person and monitor them until the EMT arrives. So let's just walk through those steps quickly. So you saw it in the video. You see my friend Mary Wheeler up here doing it to her co-worker. She's rubbing her knuckles firmly into the chest area, the sternum. She could also have rubbed her knuckles into this person's their gums. And at the time, you're saying, I'm going to give you naloxone, I'm going to call 911. The person doesn't wake up after a minute or two. You should assume that they're in an opiate overdose. And the first thing you want to do is call 911. And when you call 911, you want to just tell them that you're with somebody whose breathing has stopped. The recommendation is you don't get into the opiate issue because there is that stigma that we know about. And give them a clear address so they know exactly where you are. And then if you have to leave for any reason, put the person on the side so they don't aspirate. So that there's techniques to doing that, which are listed here. But the most important thing is you get them on this side so that they don't, choke on their own vomit. The other thing is that Massachusetts and most other states have Good Samaritan laws now. So, and this is really to encourage people to take action. So, one of the problems that had existed, I'm sure still does exist, is most of the people who witness an overdose, most of the bystanders who witness an overdose are there, also using, so they're high and they were reluctant because they were afraid they might get blamed or arrested for using drugs. So the Good Samaritan laws exempt people from criminal liability when they're acting in good faith. The other thing, people that it deals with the civilians who are going to walk by and say, if I intervene and I do screw things up, I might get sued civilly. So as long as you're acting in good faith, you'll be exempted from civil liability. So if you have Narcan, naloxone, and you can get that now over the counter, that just happened, I think, in the last 6 months or so. But you can get it at any pharmacy in Massachusetts. And I haven't checked with the over-the-counter. I know when it was being held behind, when you could get it it was a prescription drug, but you could get it without a prescription, the insurance covered it. I hope it still covers it, but I did see it in CVS for $44. So we'll see. But in any case, every pharmacy has it. There are a lot of harm reduction groups who also have it and will give it out to people who will go in and request it. But having naloxone more available is a great idea, right? So everybody from the Surgeon General on down have increased for easier, more people carrying it, more people having it. So and hopefully you'll carry it but never need it. So there used to be these 4 separate devices, but it really has come down to nasal Narcan now. So we're not even going to talk about these other 3 anymore because unless you're in a harm reduction group, which is actually, this is the predominant form of naloxone that gets distributed. It's syringe-based with these vials. It's the lowest cost of these. These 2 are basically off the market. This one was the assembly one. This one was called the Talkie, but they priced themselves out of the market. So this nasal Narcan, and now there's 2 or 3 generic on the market. So hopefully the price will come down and stay down. I mean, it's very inexpensive stuff, less than $1 to actually make it, and the dispenser itself probably costs another $1, so it's probably a $2 product at cost, would be my guess. And so let's talk about I don't want to get into the details of the emerging market, but let's talk about how do you use it. So it's a very simple, straightforward way. So
Hi, I'm Allison, a pharmacist, and today I'd like to go over how to use your naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video in a pre-filled syringe.
okay, we skip over the pre-filled syringe now. So this is really all you need to know. Simple, easy.
This is Narcan nasal spray. It comes in a box with 2 doses. You're going to take 1 dose out of the box, remove it from the packaging, and the applicator goes in 1 nostril, and you're going to depress the plunger with a quick, firm push. When putting in the applicator, you'll want to form a tight seal with the patient's nose so that the medication goes up into the sinuses and does not come down the face. And then with a quick, firm push, you're going to administer the medication. There's no need to depress the other nostril. You can leave it open. And if a second dose is needed, you will apply it in the other nostril than the one that the first dose was given in. And that's how you use the Narcan nasal spray.
Okay, so simple. Thousands of people without any training use it across the country every day. Highly effective. So if you have it, somebody's in an overdose, give it to them. You can give multiple doses to people. Sometimes, particularly with the fentanyl and its potency, people sometimes take 14 or 15 doses, but hopefully after a dose or 2, the person starts breathing on their own. But if you don't have it, or if you do have it, and after the first dose, they're not breathing on their own, then you want to do something called rescue breathing, or if you know it's CPR. And with rescue breathing, all you need to do is lay a person on his or her back, tilt their head back, open their mouth, pinch their nose, cover put a seal with your mouth over theirs and give them 2 sharp breaths, so enough so their chest rises. They're going to do that for a couple of minutes, just to let the naloxone, the injection of the nasal spray that you've given them, let filter through the system. And so you're going to do that for 2 or 3 minutes. If they're still not breathing on their own and you have more naloxone, give them another dose and go back to rescue breathing. If you don't have naloxone, do the rescue breathing. You want to try to get oxygen to their brain until EMT arrives, because EMTs will have naloxone. EMT or police or fire, whoever, they almost universally now carry naloxone, and that'll be the first thing they do. So it's and then what's important is you stay with the person until help arrives. In Massachusetts, they'll be offered. So let's say that you're able to revive. So if the person has not been revived, then they'll just be taken to the emergency room. If the person, if you've been able to revive the person, they're breathing on their own, they're probably going to want to take off. But you want to encourage them to go to the ER. In Massachusetts, they're not required to go. And once they get to the ER, they won't be arrested. They're not required to stay. But they'll be monitored for 3 or 4 hours. If they go in a hospital in Boston, then there are clinics now focused on the opioid epidemic. The one at the Mass General is called the Bridge Clinic. They'll be given a recovery coach. They'll be offered a buprenorphine prescription. They'll be given naloxone to take home, and then they'll be also given free follow-up counseling if they choose to do it. So, and many people don't, but if somebody really wants to start down the pathway to recovery, that would be there. But in any case, stay with them until help arrives, and if you have any control over them, make sure they go and get monitored, because the risk of having another overdose even without using more opiates exists because of the potency of the after the naloxone wears out off. So in any case, the acronym SCARE-ME: stimulate, call, administer naloxone, do rescue breathing, give a second, third, fourth dose, move the person to a recovery position, and then stay until help arrives. So let's talk a little bit about what you can do to help one person. So carrying naloxone is certainly one thing. Another thing that you can do is educate about the risks. So it's not unusual for somebody to be unaware of how risky these drugs are. Somebody gets a prescription from a dentist or doctor or emergency room physician, and it could set them on a path that is life changing. So you want to make sure that your friends and family know the risks related to opiates, and then in terms of educating as future healthcare professionals or just people generally interested in helping others, helping people understand that there are alternatives available to opiates. So and educate about the need to dispose, right? So this is something you can all do. You could do it, when you go home, or at spring break or whatever, and check your parents and your grandparents and medicine chest and see if they have anything there that might cause harm to others, and find out, do they still need it, right? And if not, then the best thing to do is to dispose of it. Disposing of things, typically, almost every police station now in Massachusetts has a disposal box. No questions asked. You go into the lobby, put the drugs in there, and leave, and then they'll make sure they're incinerated. Most communities also have drug take back days. Those usually get run a couple of times a year. And there's now also some at home drug deactivation kits. And I ran a program in 9 communities in Massachusetts to hand those out. And so those work pretty well too. But there's a bunch of ways to get rid of it, and getting them out of the home is really critical. So I talked about the 90% of general surgery patients are given more opiates than they need. 75% patients report their prescriptions were not stored in a locked container, and most people do not dispose of them, even though they don't use them. So tell people about naloxone, Narcan. If they know somebody who has an opiate prescription, even if it's legitimate, and they know somebody who's struggling with opiates, go get some Narcan, carry it with you, keep it in your house. It's relatively inexpensive, and obviously can save a life, right? So the stigma issue is huge, right? So it starts with each of us, right? To start to change our mindset about this, who's to blame here, right? So fair game to blame pharma, fair game to blame the FDA, fair game to blame doctors. Personally, I don't think it's fair game to blame the user. So hopefully you'll come to that. And then advocate for common sense things, the right to know, right? This exists in 16 states. Right to know, basically, opiates. So if I prescribe an opiate to you, I have to tell you about the risk for dependency, the link between prescription drugs and dependency, and heroin abuse, and alternatives. Advocate for increased access to medication-assisted treatment, right? So methadone, buprenorphine, and naltrexone are all highly effective in helping people who want to be in recovery, but getting access to it is still a challenge. It's still a big challenge. So getting more prescribers waived and so forth. Yeah. So this one was something I had advocated for before in Massachusetts as well, but which New York was the only state that actually waived the copay for naloxone. So if you went into a pharmacy in New York and there was a copay, they billed the state for the copay. I was hoping Massachusetts would pass a law, but that never came to fruition. So, okay, warning labels. I think New Jersey is the only state where there's a warning label about the risk of overdose and addiction on clearly labeled and easy to see on every opiate prescription that gets handed out. You know, there's a very detailed form that you get in Massachusetts, but nobody ever reads it, and it usually ends up in the trash. So, so what else? A couple of other things I want to share with you. Okay, so I want to just share with you some of the things that people are doing. So this is Dr. Kolodny, and he, as I mentioned, pharmaceutical industry has tried to get him fired at Brandeis. There are actually healthcare providers who really resent him, and I think to a large extent it's because when you speak truth to very powerful people who don't want to hear it, you know, that's, you know, but he's been very outspoken about, and you know, you heard him briefly, and you can see that, you know, so there's a whole harm reduction movement out there. This is one of my friends, Mary Wheeler. She runs Healthy Streets up in Lynn, and these are clinics, drop-in clinics. She gives people naloxone. She does blood testing, you know, because people are very susceptible to, you know, Hep C and other things when they're sharing needles. And she also has access and knows, you know, how to get people into treatment if they want it, right? So, and then there's a big movement in the law enforcement. Law enforcement has done a 180, thanks in large part to this man right here, Leonard Campanello, who was the police chief in Gloucester, and he was really the first law enforcement official who said people started coming into lockup and they were addicted to drugs. He said that he was no longer going to treat them as criminals. He was going to find them a place to get treatment. And so he really started this movement. And there's a nationwide organization called Perry that is based in Boston. I think they've got about 500 police forces across the country. And there are other similar organizations, but basically most, I shouldn't say most, but many of the law enforcement agencies now, rather than treating people who are using as criminals, they're treating them as having a health issue and trying to encourage them to get into treatment and not locking them up. So and still going after the people who are dealing, obviously, but so this another woman who I've had speak at MCPHS. She developed and now has a regional organization that basically support group for. So a lot of times family members and loved ones and friends who know somebody who is dealing with opioid use disorder have no idea what to do. So these are groups you can attend. They're called Learn to Cope, and you can go and you can hook up with other people who are in the same situation, many of whom have, you know, navigated the pain and the difficulty of trying to help somebody who's suffering with opioid use disorder. This gentleman, I've also had speak at MCPHS. He's I don't know if he still is, but he was an emergency room physician at the Mass General, and he really got interested in getting all the ED physicians at Mass General waived to prescribe buprenorphine. So when he started, there were, I think, 3 of them, and when he was finished, there were 146 of them. And I know we talked about bringing it beyond that, but in any case. So, and there's plenty of others out there. There's a website that one of my students created. It's called the Opioid Epidemic Network. And on there, you'll see other people, Dr. Sarah Wakeman, Lippy Roy, Fred Ryan, and others who are doing good work. So if you're looking for inspiration or ideas, there's plenty of them out there to get you going. So, all right. So it looks like I'm running overtime. So are there any questions? Okay. So there's a couple of discussion board assignments. Thank you for your time and attention today. And I'll see you all on Monday. I'm sorry, Tuesday.
Thank you, Professor.
Thank you.
Thank you.